This is the exact question that fails final year vet students every year. A young dog is having seizures. Is it idiopathic epilepsy or something that will kill the dog if you don't start immunosuppression today? You see a 2-year-old dog with acute seizures. Your 3 most important differentials in this age group are idiopathic epilepsy, meningoencephalitis of unknown origin, MUO, and steroid-responsive meningitis arteritis, SRMA. The biggest mistake students make is jumping straight to epilepsy without first ruling out inflammatory brain disease. Always start the same way. Perform a full neurological examination between seizures when the dog is not post-ictal. If the dog is completely normal between seizures, no ataxia, no cranial nerve deficits, no neck pain, no behavioral changes, no proprioceptive loss, then idiopathic epilepsy becomes the most likely diagnosis. Remember, idiopathic epilepsy is a diagnosis of exclusion. The interictal neurological exam must be 100% normal. Same 2-year-old dog, same seizures, but now you notice marked pain on cervical palpation. That single finding completely changes your list. Severe neck pain plus fever in a young dog equals steroid-responsive meningitis arteritis, SRMA, until proven otherwise. SRMA is an immune-mediated disease that causes inflammation of the meninges and arteries. It mainly affects dogs under 2 years, especially sporting breeds and hounds. Classic presentation includes high fever, marked cervical hyperesthesia, and a reluctance to move with a hunched posture or stiff gait. Bloods often show neutrophilia and very high C-reactive protein. CSF typically reveals marked neutrophilic pleocytosis. Meningoencephalitis of unknown origin, MUO, is also inflammatory, but the picture is different. Seizures are common, but you almost always see multifocal neurological deficits, ataxia, head tilt, or cranial nerve deficits. Fever is uncommon. CRP is usually normal or only mildly elevated, and CSF typically shows mononuclear pleocytosis. On MRI, you'll see multifocal T2 hyperintense lesions in the brain. Toy breeds and terriers are overrepresented. Use this simple rule: seizures plus completely normal neuroexam equals idiopathic epilepsy. Seizures plus multifocal deficits, think MUO. Seizures plus neck pain and fever, think SRMA first. Age and breed then help you rank the list. Being under 5 years increases suspicion for SRMA and MUO. Idiopathic epilepsy is managed with anti-epileptics. SRMA needs high-dose prednisolone, while MUO requires steroids plus stronger immunosuppressants. If you treat MO or SRMA as just epilepsy, you delay life-saving immunosuppression and the prognosis drops dramatically. So next time you see a young dog with seizures, ask yourself, is this purely idiopathic epilepsy? Or is there evidence of inflammatory structural brain disease? That one question is what separates the students who pass from the ones who fail.